her thesis, AI Imaging in Pediatric Oncology, Methods and Clinical Application. I have opened this academic session and I welcome you and wish you lots of success, dear candidate. And I welcome also the promotion team, Professor Aerts and Dr. Mak, and of course the members of the opposition, whom you will meet a bit later, and all guests, friends and colleagues online. We look forward to a nice PhD session. But before we start the opposition, I would like to ask the candidate to present for family and friends what she has, what her thesis is about, what the subject and the results of your investigations, your research. The floor is yours.
Good morning. Good afternoon. Thank you so much. Everything's looking all right. You can see my screen.
Yeah.
Perfect. Dear Prorector, dear members of the committee, and dear members of the audience. In the next 15 minutes, I will present my PhD thesis on AI imaging in pediatric oncology, focusing on methods and clinical applications. Before we proceed, I ask that we take a moment of silence to honor memory of all Ukrainians who have given their lives defending my homeland, as well as all the innocent victims. Thank you. Let's begin. Pediatric brain tumors represent the most common solid tumor type in children, affecting over 5,000 kids in United States alone annually. Survival rates vary substantially based on the tumor type, anatomical location, and biological aggressiveness. Importantly, survival alone does not capture the full picture. Many survivors face lifelong challenges stemming from both disease and its treatment. Despite the high survival, morbidity and complications are a high problem, with over 95% will suffer from chronic condition related to diagnosis or treatment. Due to the risk of the recurrence and treatment-related complications, pediatric brain tumor patients undergo extensive imaging surveillance. A typical patient receives 8 to 15 MRI scans over approximately 8 years. An MRI, or magnetic resonance imaging, is a non-invasive diagnostic test that uses strong magnets, radio waves, and a computer to create detailed images of organs, soft tissues, bones, and blood vessels. During the first 1 to 2 years post-surgery, scans may occur every 3 to 6 months, so we have a lot of imaging data. This frequent imaging generates substantial longitudinal data that until now has been underutilized for monitoring patient health beyond tumor status. A critical late effect in this population is obesity or overweight. Cross-sectional data shows that approximately half of this pediatric brain tumor survivors are classified as overweight or obese. It also accelerates the chronic disease development, compounds endocrine dysfunction, already common in this population, and it increases the functional limitations. Poor quality of life places lasting burden on survivors, and current monitoring relies on BMI, body mass index, that is measured sporadically during clinical visits. This thesis asks, can we do better by extracting body composition information from the brain MRI and beyond these patients that they receive? So now that I placed you a little bit in the context, I will get down to the 2 main parts of my work. First section will address the AI-based body composition assessment from the brain MRI. Sarcopenia, which is a fact where a loss of muscle mass strength and function happens, it affects substantial proportion of pediatric brain tumor survivors. And the clinical significance extends just beyond the simple muscle loss. Sarcopenic obesity, where patients simultaneously lose muscle while accumulating fat, represents a particularly hazardous metabolic state linked to increased cardiovascular risk, metabolic syndrome, insulin resistance, and mortality. This body composition shift is especially concerning in pediatric brain tumor survivors, given their already elevated baseline risk for metabolic complications from cranial radiation and a hypothalamic damage. And studies show like really high prevalence in this population, depending on the treatment exposure and follow-up duration. So we're really interested in this proportion of bone, muscle, and fat. What are some of the ways that we can measure those and why BMI is not enough? You probably all heard about BMI. It's measured routinely, very easy to measure. It's just weight divided by height squared. And it's useful at the population level. It fails to distinguish between fat mass and lean mass. Two individuals with identical height and weight can have vastly different body compositions, as shown here. The person on the right, despite a higher BMI, might have substantially more muscle mass. Current body composition assessment methods include handheld bioimpedance devices, which lack precision, and DEXA scans, which require dedicated equipment and additional radiation exposure. Brain MRIs are already routinely obtained, as we've seen earlier, in pediatric brain tumor survivors for surveillance. Yet the imaging field surrounding the brain, including muscle and fat compartments, is typically ignored. Previous studies have demonstrated that skeletal muscle measurements at the C3 level correlate with the temporalis muscle measurements on the MRI, suggesting that brain imaging could serve as radiation-free tool for body composition assessment in this population. In Chapter 2, published in Nature Communications in 2023, I proposed develop deep learning system called ITMT for automated temporalis muscle quantification. The temporalis muscle, which is visible on routine brain MRI scans, has been shown in adults to correlate overall with the body muscle mass. Here, we suggest to use this pipeline for children, and our pipeline takes a standard T1 weighted MRI as an input, automatically segments the temporalis muscle, and outputs a thickness measurements in millimeters. We then created normative growth charts similar to the BMI growth charts. And this would enable clinicians to plot a patient muscle status against the age-matched reference populations. We ran this method, this deep learning method, on a large cohort of 23,000 of normal brain MRIs from 13 independent open source imaging brain studies. And we created these growth charts for ages 0 to 30. So what does it allow us? On the left, you see a picture, what does the normal BMI growth chart looks like? And on the right, you see sex-specific temporalis muscle growth charts for male and female, and how they might look like in the hospital for treatment, during the treatment and follow-up. So male trajectories are shown in blue, female in orange. The bands represent percentile ranges from 3 to 97. And a clinical scenario illustrated here in example in both female and male chart. For example, a patient gets diagnosed with brain tumor, shows a progressive decline in muscle through the cancer treatment. The decline that could be potentially missed by BMI monitoring alone could trigger supportive nutritional or physical therapy treatment. The charts were derived from over 23,000 MRIs. So in Chapter 3, accepted for publication in Lancet Digital Health, still in press, we applied this method longitudinally to 730 pediatric brain tumor patients with different disease types. This figure shows a single example of the patient trajectory. Again, we have someone diagnosed at early age with a brain tumor. And then we have a blue line highlighting the BMI progression and weight. And then we see the temporalis muscle in really low part of the centiles, which is not visible on just BMI or weight alone. So this case is a great example of how muscle loss can be masked by stable BMI. So with this great tool that allows us to automatically calculate the temporalis muscle across a variety of cohorts. We found that TMT, sarcopenia, and sarcopenic overweight were really common pattern, which occurred at least in most of the 72% of the patients, with high variability dependent on tumor diagnosis and treatment received and origin of the tumor. Nearly half of the patients with sarcopenia had an occurrence that coincided with normal or above normal weight, highlighting that BMI alone is insufficient to detect sarcopenia. In the next chapter, we take a step further. We move to the full body composition from a single MRI image. In chapter 4, we extend beyond this temporalis muscle to the full extracranial tissue segmentation. We developed TissueNet, a neural network that segments subcutaneous fat, skull, and muscle volumes from the brain MRI. This pipeline generates volumetric measurements for each tissue type, which are often localized to anatomically consistent regions of interest using brain-based atlas registration. This enables creation of the tissue-specific growth charts, expanding the scope of opportunistic body composition assessment. And here is an example how it might look like on the brain MRI. Segmentation in yellow is a fat, skull segmentation is in blue, and the green segmentation is temporalis muscle segmentation. Let's move to the section 2, which addresses brain age prediction. A little bit of the background here. Neurocognitive outcomes represent a critical domain that's affected by pediatric tumors and their treatment. That includes quality of life across communication, relationships, social activities, and independence. Drawing from a really large body of research in adult neurodegeneration, in particular Alzheimer's disease, brain age, which can be quantified through the neuroimaging, can deviate substantially from chronological age due to various factors, for example, genetic and environment or treatment effects. This diagram here conceptually demonstrates this. The red line represents healthy aging, where brain age tracks chronological age, and the blue line demonstrates a case, for example, following an event like cancer treatment or some other impact event, where brain age might deviate from norm, either accelerating or lagging behind, with early identification of this deviation enabling targeted interventions before clinically apparent decline. So in chapter 7, published in Imaging Neuroscience in 24, we developed Age-Diffuse, a diffuse-based deep learning model for brain age prediction. This model takes as an input, again, just a single MRI, T1 weighted, at multiple coronal slice position, generated predictions aggregated into the final brain age estimate. To be exact, there is 5 model aggregations taken together to create a final prediction. Brain age represents the apparent biological age of the brain based on structural features. Deviation between predicted brain age and chronological age, termed the brain age gap, has been associated with neurological disease and cognitive decline in adults. So again, I want to show you an example how it might look in clinic and what in particular we are looking for. So here we see the patient who was diagnosed with pediatric medulloblastoma, and we see the difference in the brain age gap compared to the chronological age. And at a certain point, the brain age gap becomes really large. And then what we did correlate this to the verbal learning scores that this patient underwent. You will see a lot of missing values because these patients don't take those tests at every single MRI visit. That's why data is relatively sparse there. However, what we've seen here is that verbal learning in this particular case, verbal learning large deviation correlates well with the large brain age gap, indicating something that's occurred in the brain age. So now that I presented to you those 2 different methods of the brain age and the temporalis muscle and the fat and the subcutaneous fat estimation, I wanted you to understand how it could be possibly integrated in the routine MRI screening. So this schematic summarizes the clinical workflow. Patient will undergo longitudinal surveillance with repeated brain MRIs. From those existing images, we now can extract automated measurements, enabling automated detection of malnutrition, sarcopenic obesity, and prediction of long-term functional and cognitive status, all without additional testing or patient burden. In summary, this thesis makes contributions across 3 domains. Scientifically, we discovered and validated 2 novel MRI-based imaging biomarkers using AI. Clinically, integration of this automated biomarkers into routine brain MRI has potential to improve survivorship care by detecting treatment-related morbidities earlier. From a community perspective, all tools, code, and reference charts are open sourced, enabling other institutions to adopt and extend those methods. The overarching goal is to improve long-term quality of life for pediatric brain tumor survivors. I would like to thank my supervisors, collaborators from the AIM program, Dana-Farber, Boston Children's Hospital, and CBTN PNOC Consortium. I'd like to extend my special thanks to the CanLab members who contributed substantially to this work. I would like to thank my mentors and my daily mentors, specifically Professor Hugo Arts and Dr. Benjamin Kahn. Thank you so much for your attention, and I'm really happy to take your questions.
Thank you very much for a clear presentation. And we are now going to start the opposition. And the first opponent is also the chair of the assessment committee. That's Professor Dekker. He's Professor of Clinical Data Science in the University of Maastricht. Professor Dekker.
Thank you, Mr. Prorector. Dear candidate, let me start by congratulating you on a lovely thesis, which I read with great care, but also enthusiasm and enjoyment. Let me also extend my congratulations, not just to you, but also to the supervisory committee that helped you, and also your friends and family and colleagues that in Ukraine are going through a very rough time, and you're commended that in these times you've completed such a great thesis. So congratulations on that. I wanted to start the discussion with you on proposition number 2, and which you also just described in your layman talk about chapter 7, which is brain age, right? So, you have been in this group with your supervisory team for a while, and they are kind of fan of this age concept, right? So they have face age, they have brain age. I know, well, not from them, but there's metabolic age, and there's just age, obviously, right? So what's your view on all this age stuff, right? Are we going to have an age for every single organ? What are we going to do with that age? I mean, typically you can't do anything about the age, so why would we care? What's your viewpoint on age?
Dear highly esteemed opponent, thank you so much for your kind words and for your excellent question. It's a really good point on the different concepts of age of the different tissues and how do we integrate them later. I think ultimately we're moving towards an overarching goal of estimating age of each independent structure and moving towards the goal of precision medicine, where we can spot the deviations from the norm really early before they happen. As we know, a lot of treatment and a lot of interventions do work really better before the disease progresses really late the stage. So in my perspective, the more ages, the better.
Yeah, no, I thought you would say that, which is good, right? So I actually also don't mind that, but and I think your point is well taken that the thing about age is if you can determine it, you can see that someone is prematurely aging, right? And that may be an indicator for a disease which is going to happen in a while. So would you say that this age concept may be the basis of all these digital twins that people are making now, right? So and these digital twins could be maybe per organ or per tissue, as you said, and combined in a bigger one. Would that be the base you would start a digital twin in?
I think it's a very good 2 concepts to connect digital twins together with aging, right? Ultimately, can we create a human model that without interventions, can we predict how the treatments will affect just on the mathematical or computer or call it digital twin model without actually doing the harm? Can we create a perfect digital twin? I don't think it will be limited just on the age concept. I think it will take much more modalities. It will take pathology, it will take genetic testing, it will take other sources of it's definitely will take some hereditary stuff. But ultimately, I think that's the goal. Try to see the perfect treatment, try to find the perfect intervention, or perhaps even see it earlier.
Right, right. Yeah, and I would also say we did a bit of work on brain age in more in the dementia sphere, right? Which is obviously on the other end of the spectrum of life. Um, would you think that you would have an age per disease almost, right? So or would age be a conceptual thing that is really only on the tissue or the organ basis, or should you differentiate for a different disease for every, or sorry, different age for every disease tissue combination, which
That's
would be
a
complex, huh? Yeah.
That's an excellent point. And I think it brings up a much bigger question in science in general. Do we try to develop those model methods that are precisely targeted to the intervention, to the disease? Or do we develop now foundational models that take everything as an input and produce one aggregated output? I think my answer, I don't know which will work better. The precise models seem to work better right now just because we have limited amount of data, right?
Yeah.
Ideally, we would have all the data in the world to create
Right.
those conceptually broader models.
Well, I
However,
think the
not
nice thing about age as a concept is that you can train it like you did in normal people, right? So you have something to hold on to.
exactly,
That is,
exactly.
that is what I really like about it, how useful this is.
Yeah. However, if you think about it, is everyone considered healthy in this
Sure,
cohorts? Is
sure.
really healthy?
Yeah, yeah. But in
Or
children, obviously, this is a little bit easier than in if you're elderly, I guess, right? Let me
yeah.
move on to another question on that. So, to be honest, in proposition number one, you state rather you have a bound proposition, right? You say that temporal atlas muscle thickness is a surrogate of body composition, right?
Mhm.
What I didn't see here is in children in this. So I was wondering if you can really say this, right? Because I didn't see in your thesis a comparison between the normal body composition, right, which you state as, and correctly so, right, in one of the vertebra that you typically take, especially in adults, where you would, and there's pretty good correlation between the body composition taken there and things like sarcopenia and muscle loss.
Yeah.
But I haven't seen you do this in your studies, right? So can you stand by that proposition that this is really true?
That's an excellent question. Actually, we moved backwards. We found a large body of the literature proving that temporalis muscle correlates with is a surrogate for body composition on the C3 lever. So there is a preliminary in adults specifically, and there was another great study done in glioblastoma adult patients. So there was already body of work present on adult patients. So we were working here backwards. No one actually proved that it works in children. No one actually correlated it in children. So in that paper published in Nature Communications, we did a lot of experiments correlating temporalis muscle thickness in particular to the calorie intakes, daily steps, and activity levels, hormones, and all of the stuff. And we really saw that as a prominent feature, which makes me hopeful and positive about this claim since it was proven before for adults. However, we're really planning to do this in a future work to extend this to adult population further.
Right, right, yeah. No, because we're doing the same, right? So, but to your point, right, in kids, you don't want to do the radiation-based imaging, but in adults also, we're often stuck with certain part of the bodies where we have to look at. So I think correlating across the body, this measure is actually a good approach, yeah. Let me move on to one of the other things you say, and I don't necessarily agree with. is that you say AI models in medical imaging, right? So like brain age or like your muscle thickness one, should always be validated in independent external imaging centers to prevent overfitting and ensure generalizability. Well, if it works for me in my data, why would I care if it works somewhere else? Why should that always be done?
That's an excellent question. I think if it works for you, great. However, if it works at this time point of time, like exactly this day, this week, you cannot guarantee without proper tracking tools that it will work next week. You cannot guarantee that your MRI scanners wouldn't change protocols or new
But that's
technician
true
will come.
as well, right? If I do an external validation now, I may validate it in old scanners and the new scanners are not available there.
Exactly. So the point is more about being aware how variable the data is and that you always need to make sure that you don't lock yourself on only your targets because maybe you're really overfitting if you're really super happy with your model. That we've seen that a lot with the pediatric brain tumor patients, that model that works on one data center it doesn't generalize at all on the other data center. Partially, it is a really sparse data, really sparse, like every imaging center does something different. Nowadays, they really put a lot of effort onto trying to standardize these imaging protocols, trying to make sure that everyone at least collects a 3D MRI T1 image or something like that for research purposes. However, I'm a really big advocate for trying to validate your model on the settings that your model haven't seen during the training, because my other point is usually what happens during the research, the testing set really becomes a validation set, because you tend to try a couple of models on the same test cohort, and even though you report it as a test cohort, it really becomes
Right.
your validation cohort. So unless you test it on something completely independent, you cannot guarantee that this is not a overfitted model.
All right. Thank you very much. I give the word back to the prorector.
Thank you, Professor Dekker, for your opposition. We now come to Dr. Catharina Brunink, Assistant Professor at the Department of Radiation Oncology in the University of Bern, and that is in Switzerland. And thank you for coming all the way from Switzerland, the University of Maastricht. It's always glad to have guests from abroad and outside the university.
Thank you very much, Mr. Prorector, for this introduction. And dear candidate, it was a pleasure to read your thesis. And I also want to congratulate you on a very nice, very comprehensive piece. I particularly liked aspects where you went into really great depth of multiple data sets. It certainly was not easy to prepare for this analysis. And also regarding the last point, to really make a point about the generalization. My first question I would like to address towards proposition number 6, which is about the integration into routine clinical follow-up. I think it is always easy as an AI research group to make this beautiful claim in the end about the merit of clinical translation. And you certainly showed some excellent models here. But I wanted to critically question this a little bit, where you really see the greatest barriers in really deploying some of these tools in routine practice, and in particular here in the pediatric population as well.
Dear esteemed opponent, thank you so much for your kind words and your excellent question. That is actually a very good question, and I think my answer might be different if I was in a different imaging center. So what I've done in my work, I've developed a couple of open source tools that would help clinicians to speed up review, to try to went a little bit one step above just the AI model. So one of my model is integrated into the slicer, or like clinicians can review it really easily. However, when we move one step further to the clinical implementation, that's when the things become really, really complicated. And we are here not independent researchers that just everyone here, this is my awesome tool, please appreciate it. Unfortunately, we're facing the burden of the hospital systems and the ease of the integration. I'm seeing a positive movement in our hospital, and I've seen some hospitals where the integration are really seamless. For example, Flywheel tool that really allows you just create a Docker image, you put your model there, and it allows you access without this time-dependent DOIA that we know can take years to execute to access the data altogether. So really tools great like Flywheel that allows you to access data and run your model. I think we need to put more into trying and testing these tools with the awareness of the exhaustion of the clinicians, right? We cannot create the burden to them of here is 100 of AI tools that you need to test. Please give us feedback. So it needs to be a rather structured approach. And to your other point in pediatric population, I think it's really important to be aware of sensitive groups that we're working with and be very aware of the patient privacy and be hyper aware of the ethics and things like that. So overall, it is a really hard work of collaboration of hardware engineers, of AI researchers, and of the hospital's ecosystems, which is still work in progress.
Yes.
I myself cannot solve it, but happy to take all the help.
I mean, I perfectly agree. And I think it kind of feeds also into my second question, which is about proposition number 8, where you're talking about the abandonment of threshold-based simplifications. I will phrase this a little bit wider in the context of we need improved metrics also of assessment of different kinds of response. And I think there, in particular, in chapter number 5, you made a very good attempt on this, how you would integrate also longitudinal tracking in this context. And now my question is, as a first step, thinking about clinical implementation and what we just discussed, that probably also no model is ever going to be perfect. How would you rate the importance of displaying, for example, also imperfections in a model or uncertainties of a model in the context of these assessments?
That's a very good point, and it opens up a lot of boxes and a lot of doors that needs to be addressed. One of them, let's start from the beginning. So threshold based versus continuous. This is a really big question, and a lot of statisticians like Professor Harrell advocate for using continuous metrics. However, if you ever connect to the clinician side, they really prefer threshold based because they need to operate in such large, massive scale of data daily that continuous function just wouldn't work, right? They need a simple decision threshold. And that brings us to the human-computer interaction research, which I myself haven't done particularly in depth, but I've seen what other people did, right? There is a lot of effort on how do we present the information to the clinician in the best possible way, that they're aware that there is a room for mistake for the AI algorithm. There is a room for improvement. How do we collect the feedback from them? How do we make it that they don't get tired from this interaction with the AI system, right? And that all is a very complicated thing. However, nowadays I see how people interact with the Claude or GPT-based machines. And I see that we need to create a really, really good AI models to make sure that they're reliable and well tested, which brings to another point, right? External testing is really important with as much data as possible.
And in this context, very specifically, maybe for this application of this longitudinal prediction model. So what I saw here as a big limitation was that you effectively validated this model only at the end of the trajectory, where potentially your trajectories had already, how would you say, established a longitudinal trend. How would you rate this in the context of clinical application of such labels, or what would still be needed to facilitate that?
Yes, to your point on validating on the end, this was specific cohort that was collected with the help of Dr. Tabitha Cooney. So it was focused on the endocrine disorders and neurological outcomes. And it was a great cohort in terms that patients were followed up routinely. And it would be a mistake not to tap into that cohort, not to take a look at how does temporalis correlate with the endocrine disorders. Moving backwards, we did try to collect all possible data back in the time. I don't remember how many exactly patients. I think 730 patients were collected to plot longitudinally from the start of the disease. Of course, there will be sparsity of data. Of course, there will be patients miss their follow-up appointments, and probably there will be bias towards trigger event happened and there will be more MRI scans, or progression happened, there will be more MRI scans happen. So what I think on this topic, and personally, is that democratization of MRI access, more wide accessible access to MRI, faster protocols. There is a lot of research of really fast speeding up those MRI reconstruction things to make sure that MRI becomes a really accessible tool that's present not only during the really adverse effects, but rather as a standard of care, perhaps. But I don't believe we're close to that, but it looks like that it's more moving towards that.
All right. Thank you.
Thank you, Dr. Bruing, for your position. We come to the following opponent, who's also a member of the assessment committee. That's Professor Khan, Professor of Radiology in the University of Pennsylvania, and that is in the United States. And thank you for coming all the way from the United States. The floor is yours.
Yes, thank you, esteemed Director. Dear candidate, well, I would like to join in extending my congratulations to you on the really very accomplished thesis and your presentation today, which was quite comprehensible and provided a very nice summary. I guess I wanted to focus my comments primarily to your proposition 8 and perhaps to number 9, and maybe following on the last opponent, and that I guess personally I've always felt that we've had a need in the past certainly to discretize data. We do it with our TNM staging for cancers certainly, but in doing so we lose information, and keeping that information in a continuous variable has its value. But I wanted to ask what challenges that you see, both. I think you answered a little bit of it in terms of the conveying that information to physicians, right, in the act of clinical practice. But what other challenges do you see in maintaining that information as continuous rather than discrete data?
That's a very good question. First thing, highly esteemed opponent, thank you so much for your kind words and your appraisal on my work. That really means a lot. To your question, I think number one issue would be, how do we convert all the retrospective data that was made as a classes into continuous variable, right? So if you think about that, it's not just a number 1 to 3, but there is something between number 1 and 2. How do we know the disease stage exactly if we move to continuous scales? How do we convert if we decide to move to continuous scale? So I think the issue would be with changing those standards, and I don't really have an answer how to approach that. Second problem would be perhaps with all the big changes is communication is key, and making sure that clinicians are on board with that and like asking them what they think is best and like aggregating their opinion among a lot of people, right? And educating on why continuous is not always the great answer, why binary is not always a good answer, why do we need to move towards continuous scales, why do they capture information in a better way than just discretization and just using simple thresholds. So those are two things that I can think of. And of course, the issue is always, okay, how much do we want to actually go into details of when we will be classifying, as you brought up, right? The cancer classification. Do we just go with the decimal? Do we go with hundreds of points? How many dots, how many numbers after the dot will we keep, right? How detailed will our scale become? And is it really useful in that way? So while I'll be still advocating for the continuous scale, because there is always this, it's just too simple to treat yes or no on such a complicated answer. There is a lot of caveats and a lot of things to be aware in that.
Yeah, no, how does the sparseness of data that we deal with, does that play into this? Does that
That
lead you more towards discrete or continuous variables? What is your thought on that?
absolutely sparseness of the data. Thank you so much for bringing it up. That's one of the other issues that, right, we might have more patients collecting on one spectrum of the scale, and we might never collect for the brain tumor, right? This follow-up, we don't really have a good data set of a healthy patient, healthy child follow-up longitudinally. It just doesn't exist publicly. No one followed up a healthy kid for like 10 days and rescan. It's just like it just doesn't exist, right? So we have those massive scales of pediatric patients with the brain tumors with longitudinally, but we don't have anything to match it to, like no healthy patients. So we will definitely have that issue of like more patients collected probably with disease and less healthy.
And does the choice of discrete, and when I think of discrete variables, I'm not just thinking of binary, obviously, I'm thinking of,
Yep.
something perhaps a little more than that. But does the difference between discrete and continuous variables, does that play into understanding uncertainty around the measurements that we make?
Absolutely. That's an excellent. I also think it's not just binary. It's more categorical variables that we're talking about. There, short answer, yes. I think you summed it up perfectly. I have nothing to add to the comment.
I am not eligible for a degree, however, in this by this august body, unfortunately. I guess I'd also like to touch into your proposition number 9 here regarding complexity and how we need to address that. Does that work against explainability though? Just be interested in your. I don't argue necessarily with your proposition, but I'm just curious as to how, in a situation where all we have is a deep learning model that says, yes, I've crunched this giant amount of data and here's your answer, that occasionally some reductionism is helpful for us poor humans to understand the output. And I guess I'm just interested in your thoughts on that.
This is highly philosophical proposition that I have there, right? Because we always make those trade-offs on, okay, so we collected this really small cohort and the model really works well. We don't know what other diseases this cohort might have, and we choose not to include them. There was a lot of, right, and we cannot always accommodate for the variety and complexity of the variables that we have, right? We will be happy if we have the data set large enough to accommodate for sex. We will be happy if we have the data set large enough to accommodate for ethnicity or social determinants of health. But we will never have, right, the perfect data set that will allow us to model that complexity that exists in the nature, in the universal world around us, right? Because we cannot just collect the whole universe, ask them to take a brain MRI scan for the research purposes. So I think making those trade-offs is totally okay. And my science brain says me, well, there will be prevalence of some disease, so that's what effects we will see. But there is always this hidden effect of when the models tells us something and when it doesn't work in the other cohort, do we really know what the model does, or did it learn some other feature from this data set that we think that it works on, right? And this brings us back to the topic of this: do we make a very detailed model on each organ, on this age, on the face age, on the brain age, or do we make like a human age? And I don't have an answer for that either. Hopefully, we will learn how to summarize the data that AI models generate, computers generate, right? Because something to think about is, again, daily interactions with those AI models. Not a lot of people, not a lot of researchers will read into very detailed output of what model produces. If your model produces more than like 2 pages summary, gosh, who will read to the second page? You really need to make sure that your data is presented in a way that it's prioritized, right? The most important feature, the feature relevance is sorted, that your biggest problems are shown first, so that in case the latest piece of information is missed, it's okay. It's not too dramatic.
Okay.
Thank you very much for your responses. Hopefully that
Thank you.
concludes my time.
Thank you, Professor Kahn, for your opposition. We now come to the following opponent, also a member of the assessment committee. That's Dr. Akers, and she's Associate Professor in Neuroradiation Oncology in the Department for Radiation Oncology at the University of Maastricht. The floor is yours.
Thank you very much, Mr. Prorector. First of all, my warm congratulations to you and your supervisors, family and friends within and outside of Ukraine on this impressive thesis and the body of work it represents. It's a pleasure to discuss with you the interesting research today. First of all, I was intrigued by your book. I read it with much pleasure. And in your introduction, you aim that to transform routinely acquired and underutilized MRI features, you can look into clinical actionable biomarkers. And I was wondering, could you outline specific clinical actions these biomarkers might trigger into day-to-day practice?
Dear esteemed opponent, thank you so much for your kind words. So in this work, I highlighted 2 types of biomarkers. One that are specific to the body composition, and one is brain age, which is closer related to the cognitive stuff. I will address those 2 separately. So for the body composition, surrogate measurements such as temporalis muscle, subcutaneous fat, and skull volumes that can be measured from the brain MRI only. Some of the interventions that we can include could be nutritional support, or could be resistance training, or could be help with the dietitian consultations, stuff like that. On the different stages, it would depend, of course, on what stage of the disease, follow-up, and what age is, and maybe prescribed exercise intervention and so on. And as for the cognitive stuff, it becomes a little bit more trickier since I'm personally not aware, like the raw stuff, that there's a body of research that supports cognitively, like different tasks that you can train your mental health, your simple math, you solve equations and stuff like that. But that is a little bit more complicated than just take a pill and you'll be well, right? It's a little bit more complicated than nutritional support, for example, for a patient. Cognitive support, it's a much complicated task, since it also depends on this quality of life concept. Is just very, very complicated, right? It intervenes with the functioning in school, if for pediatrics, functioning in the society, and all of these things are so highly, right? You cannot take a child out of system. It's already presented in the system. It's a very complicated task. How do you make sure that it feels supported, and what's the best standard of care there? How you can support the cognitive stuff?
Yeah, thank you. I think I agree with what you're saying, that the one is better to influence TMT, can help better. You can do something about it than brain age. Do you have any evidence? Of course, I was curious, but are there data within your study or in literature that if you reverse sarcopenia, that would eventually lead to improved survival or treatment tolerance? So is it relevant to change it?
That's a very good question. I'm not aware if reversing it. I will be just drawing the evidence. I've seen the evidence that, they just compare cross-sectionally people with a good muscle status compared to sarcopenic ones, and those with a better muscle mass, they do better. But I'm not aware of any studies that do reverse treatment and then study how well they undergo the treatment. But that's actually a very good question for the future research, perhaps for a clinical trial.
Yeah, thank you. I agree. I think that would be very interesting, because that would highlight the relevance of your work. If we could promise that in future, if we know what the sarcopenia or what the problem is, and then there is an interaction, and then we can actually improve, so that would make your tool much more powerful. So that's a good idea for the future. I noted that the survivors, and you described, they have overweight. But as a clinician, I know I usually prescribe corticosteroids like dexamethasone. Aren't you worried that that might also influence the body composition and your TMT measurements?
That's a very good question. And that's actually, we wanted to collect data, but unfortunately we were limited on the data sources to study that effect, to separate it from all the other things that are going on in this population. And we plan to do this in the future work, to study effect of the corticosteroids, particularly in this population. But that's an excellent point. Thank you so much.
Okay, I can imagine that it's also limited data, right? If the patients
Exactly.
actually have used it. Yeah, I can imagine. So also what I was thinking is, if we irradiate children at an early stage, radiotherapy influences growth. And do you then still consider the TMT to be representative as a marker in this specific population if they have had radiotherapy?
That's a very good question. Thank you so much. It's actually one of the things that we did in the follow-up work. We studied weight, height, and compared to BMI and temporalis muscle in the patients who had radiation treatments compared to those who had not. And what we've seen is that temporalis muscle has much better delineation in those patients who underwent, and in particular, when we correlate to outcomes for endocrine disorder, temporalis muscle was a better predictor of endocrine disorder. However, that being said, that was our institutional cohort. It would be great to validate this externally on other cohorts if such data exists. But yeah, this is a great point. And to your right, there is also this hormonal. Do we know how that goes into the play with radiation treatment? Do we know how we see the bone, right, grow stagnation in those patients due to various treatments? Do they then recover? After what time do they recover to growth? Do we know if that's dependent on the dose, right? It's not just, do we know if the place where they get the radiation, not the place, but sorry, the region of the brain, does that impact? Because we know some, right, if it's impacted directly into some regions, that they will have the more growth stagnation, then it's not directed to their pituitary axis. Or so it's really a very, very complex, which I think just goes beyond just received radiation treatment or not.
Yeah, thank you. I agree. And I think also dose is a factor in location, because sometimes I see patients have been irradiated in their face. You can see the asymmetry in the face occurring. So I think this is, I agree with you. This is a very complex area. And I will thank you very much for the questions and give the word back to the prorector.
Thank you, Dr. Akers, for your opposition. Now we come to the following opponent, who's also a member of the assessment committee. That's Professor De Ruijser, who is Professor of Radiation Oncology and Respiratory Oncology in the Faculty of Health, Medicine and Life Sciences at the University of Maastricht. And today he has also accepted the role of Secretary of this committee, for which I'm very grateful. The floor is yours.
Thank you very much, Mr. Prorector. First of all, Miss Candidate, I want to congratulate you for this fantastic work, your promoters, your whole team, and also your family and friends. I say this to everybody because I know that a PhD is a burden for them as well, but especially in this situation where your family is living in. So that makes it even tougher. That's obvious. But I'm here to ask you some questions, of course. And I want to start with chapter 7 on brain age, because we have and we are still doing quite a lot of work on neurocognition in lung cancer patients, also looking at sarcopenia, that's in chapter 3. And you consider brain age as a kind of age. But my first question is actually, do you really think that that is important? And what is the correlation between something what you measure in the beginning, like the age of the brain, and something what is relevant, that's cognition? Do you think that there's a good correlation, or is this just something where you say, well, there's a correlation, but there's no functionality in there? What's your opinion?
Dear highly esteemed opponent, thank you so much for your kind words on this excellent question. I'd like to address it in two parts. First of all, in how do we know that we are measuring against what is the brain age conceptually? What does it measure? So, first of all, there are studies that are isolated, but it's quite interesting to read what people try to correlate brain age to. And what I found in my literature, for example, musicians have a better, like, reduced brain age gap, right? Their brain appears younger than those of the same age, or people who practice yoga, and they also, or monks, they also have reduced brain age. So there's all of this fun esoteric studies out there that correlate to the different brain ages. And of course, this work is based largely on the studies in the older population on Alzheimer's disease, there where a lot of work on the brain age has been done, and where people see those larger brain age gaps and larger cognitive declines. So hypothetically, this would transfer on children, right? However, to your second point, what does it tell us? What does it exactly measure? So there is a variety of brain age models out there, right? There is one that measures surface of the white matter, and for example, in a graph neural network, and that presents in a way into the connection to the brain age. There is another method that measures local brain age. It quantifies the structures.
Sorry, I will interrupt you. I will be very impolite, because I think it's very relevant. But my question is not really that. Maybe I expressed myself not clearly. The thing is, you have a brain age, but for instance, in adults, having received different forms of anti-cancer treatments for lung cancer, PCI, so prophylactic renal irradiation, but also chemotherapy, you see in general, and that's why we used it to quantify the decline in cognition in some patients, and then you have a certain brain age change. In this case, it was 3 years, by the way. But the thing is, you see that the way we measure on MRI scan brain age doesn't correlate very well with cognition, and it doesn't capture the flexibility. What I want to say is that you do have patients who return to their original level of cognition, and you don't see anything changing in the brain age. So can you explain this to me? Maybe we did the wrong MRI experiments, but how can you capture this? Or is it just prognostic, not more than that?
I think you bring up a very important question. What does it capture? Since we can visualize what regions it takes into prediction, and it's a very good point on the brain plasticity, right? That it has capacity to recover after some treatment. And I think there are a couple of things, right? We could measure against the baseline and we can estimate, okay, so if you don't see that it correlates to the cognitive outcomes, I don't think you can say, oh, then it's useless. I think it's like one of the tools that you can use in your toolbox to assess the value, the risk or perhaps stratification. I don't think you can treat it independently without the outcomes. So more work is needed on like what exactly brain age tells us, right? I don't think it will correlate 100% or 99.099 on Pearson to one of the cognitive measures. I don't think it will do that. It's just
Exactly. And when you look at your very nice chapter 3 about the sarcopenia story, actually what you see is, and that will be my question, you see something, and we see this also, for instance, in the pectoral muscle or in the psoas muscle. There's a nice correlation. But will this tell us what we should do with the patient? Because sarcopenia, we know that for many years, also if you just measure the muscle strength, that's prognostic. But what we do see, for instance, the appearance of fat in the muscle has a bad prognostic sign, which is, by the way, very intriguing because in marathon runners, it's good. So we know that this is correlated in lung cancer with the type of mutations in the cancer. So how would you, and that's more maybe philosophical question, one day don't you think that the basis is biology and the imaging can help us, but the basis is biology, or do you really think, no, what we should do is just continue to look at images and that will bring us further? How could you bring, because basically we're biology.
Um, this is a very highly philosophical question, and I tend to lean to the side where biology drives the questions, not just imaging itself. I have a little bit of faith in imaging that it perhaps can see what human eye cannot see. However, without interpretation or connection to outcomes, I think that knowledge is pretty useless. We really need to make sure that we take a comprehensive picture in place and we take a human body as a whole and not just an imaging as an isolated factor. Because right, we have all the times false positive tests. It's not just one measure will tell you that's what you need to do.
So it's about how can we, do you agree with me if I say how that the biggest problem is how can we come to causality? So basically go beyond prognostication. Do you
Yes,
agree with me or do you have other ideas?
I'm a big fan of causality myself. I wish there was a data set or a possible intervention.
You may finish your answer if you like, but it's not.
Yeah, just one sentence. I wish there was a perfect data set for to study causality, or it was ethically acceptable to create a causal data set to answer those questions. But ideally, we should move towards that model or perhaps a digital twin.
Okay, thank you very much. I give the
Thank
word
you.
to the pro-rector.
Thank you, Professor De Ruijser, for your opposition. Dear candidate, Ms. Zapaishchykova, the time for the defense of your thesis has passed, and the degree committee will now withdraw to discuss the quality of your thesis and the way you defended it. And I request that you and your company await our return and the results of our deliberations. And with that, I suspend the meeting. I reopen this academic ceremony. Dear candidate, dear Ms. Zapaishchykova, the degree committee here present online has assessed the quality of your thesis and the way you defend it. In the view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Aerts is authorized to confer upon you this academic distinction in accordance with Dutch university custom. And I invite, therefore, Professor Aerts to now take the floor.
Thank you. So, do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible? I think you said yes, but I didn't hear that. Okay. So then, by the authority vested in us by law and in conformity with the decision of the committee, here presented online, I hereby confer upon you, Anna Zapaishchykova, the degree of doctor with the predicate of cum laude, and grant you all rights attached by custom and law. As evidence of this, you will soon receive the degree certificate signed by the rector, the secretary, and the supervisor, affixed with the official seal of the university, shown now here by the beadle. Great, thank you. So now I also have the honor to do the laudatio of Anna. So congratulations. It's really an amazing achievement. So I also doing this laudatio on behalf of Anna's main supervisor, Dr. Benjamin Kahn. But I also had, I was also especially grateful to speak here today because I worked with Anna a lot. So Anna was actually the very first PhD student that took on in his lab. And as we often joke between the two of us, you can get lucky, very lucky the first time. So from the beginning, it was very clear that Anna was someone special. Even in our first conversations, we were interrupted several times by her beloved cat named Peach, who she permitted to parade around the Zoom calls without any shame. And it was very quickly clear to us that Anna was very smart, direct, unafraid to speak her mind, and very passionate about her work. And as supervisors, we could not have been more fortunate when Anna joined the group. Our expectations were very high, but Anna actually exceeded them. She combined motivation, rigor, organization, and enthusiasm in a way that made mentoring her both very easy, but also very enjoyable. And over the years, we had the privilege to watch her grow into a very independent scientist with a very strong sense of direction. What also stands out is that Anna's ability to see the big picture, while she never loses to see this, losing sight of the very small details that matter. She asks the right questions, the questions that really make a project move forward. And then she pursues the answers with discipline and intellectual honesty. And through this persistence and determination, she developed the skills to regularly test her hypothesis and to translate very complex ideas and projects into very impactful science. Her academic output has been exceptional. Her manuscripts are of high quality, and the applications she has developed, particularly those aimed at improving outcomes for children and survivors of brain cancer, will have a lasting impact on both the scientific and the clinical communities. And these are contributions that truly matter, and she should be very proud of them. But also beyond her research, Anna has embodied the lab mantra about always be learning. She proactively sought out professional development opportunities in areas ranging from scientific writing to communication and biostatistics and peer review. And she also got a role as junior editor at the esteemed journal Radiology AI, which is very impressive at any career stage, and let alone being a PhD student. What we also appreciate just as much is that she never kept all of these opportunities to herself. She actively shared a lot of them with her lab members, really raising the level of the entire group. So, you know, and all, you know, somehow along all of this, Anna also had found a lot of time to be creative beyond science. So she took up crafts like pottery and cooking and becoming remarkably good at them. And many of us here have benefited from her handcrafted mugs. They were sold around the lab with the proceeds supporting her homeland, Ukraine. This combination of creativity and generosity and purpose was very characteristic of Anna. Within the lab, Anna has been what we like to call a tide that raises all ships. So she didn't just excel herself, she made the lab better. She helped with database management, IT, GPU troubleshooting, purchasing and setting up new systems, and she even designed the lab logo. She named all of her GPUs, including the first one, which she named after the Ukrainian aircraft AN-225. And all of this sounds like very small things, but together really reflect her initiative, ownership, and deep investment into the team's success beyond her own. When we asked other lab members about stories about Anna, we were flooded with responses. Perhaps it's the Ukrainian desserts that she had baked for us over the years, but Anna always was deeply cared by and loved by her colleagues. Through these stories, we've learned a lot about unicorn face mask, Bridgerton, elaborate Halloween costumes for Peach, and her uncanny ability to judge how clean a swimming pool is. It's not only to judge, it's not only the lab that recognizes Anna's value. Our external collaborators do too, and several have tried more than once to recruit her away from us. Fortunately for us, until now at least, she decided to stay. Anna, it has been a true privilege to work alongside you and watch you grow into a remarkable scientist and a person. We know you're capable of extraordinary things, and we're genuinely excited to see where your path will lead you, hopefully in science, but also wherever in life. So please join me in offering me a very warm congratulations to Dr. Anna Zapaishchykova.
Thank you so much.
Thank you, Professor Aerts, for a very kind laudation. Dear Dr. Zapaishchykova, also on behalf of the University of Maastricht, I congratulate you with this PhD, and certainly, which is very rare in Maastricht, a cum laude PhD. That's very special. Of course, I congratulate your supervisors, Professor Aerts, Dr. Mak, Professor Kan as well, and your family and friends, and I hope and colleagues, and I hope that you can celebrate this day in one or another form, because it's one of the most important days in your scientific career. Having said that, I'm almost ready to close this meeting. I would like to thank the members of the opposition for their hard work and the discussion, and of course the PEDEL and its technical support team. Without them, this online ceremony would not have been possible. So I asked the supervisors and the members of the opposition to stay online, but we say goodbye to the audience and thank you all. And with that, I close.